75 hours, 10 seconds.
Welcome everyone to the 260. I have Parkview Regional's Medical Center team here, specifically speaking on women and children's health. I have with me Rob, Chelsea, and Kim. How are you guys?
Good.
We're doing great.
All right. So today on this session, we're specifically going to talk about OB emergencies and how we can better manage them, what some tips and tricks that you guys have. But I guess before we really dive into that, Kim, can you give us just a little bit of background on you? You're our OB expert.
Yes. I've worked for Parkview for about 25 years. Nursing is a second career, and my nursing background has been in women's and children's. I worked labor and delivery at the bedside for a little over 8, and now I work in nursing professional development, teaching nurses how to take care of labor and delivery patients, which overlaps also with NICU care, transport care, and different things like that.
And what about you, Chelsea? What's your experience?
So I have 10 years of nursing experience, most of that focused in NICU, but for the last 2 years, I have been doing critical care transport with Neopeds down in Indy, and then just transitioned to the NICU educator or professional development role.
What about you, Rob? You're
Good morning,
waiting.
Caitlin. I've actually been around for quite a while. So I started my healthcare career in EMS back in 1994. Did volunteer EMS for about 3 years before I transitioned over to becoming a respiratory therapist. Been a registered respiratory therapist with a neonatal pediatric specialty sub-certification for 24 years. My primary specialty throughout that time has been neo and peds. I've just obtained my certification for neonatal pediatric transport about 4 years ago. Been doing hospital-based transport as well for neo and peds for the last 23-ish years.
Well, a lot of experience there. So what are the most common OB emergencies that you guys are seeing right now?
I would say inpatient differentiates a little bit from field. Most importantly, recurrence of preeclampsia.
So postpartum preeclampsia?
Postpartum preeclampsia, usually latent. Generally, preeclampsia will show up prior to delivery, sometimes 48 hours later, but sometimes up to 6 weeks, sometimes even 12 weeks later. Really not sure why necessarily. Oftentimes the misnomer is deliver the baby, deliver the placenta, everything gets better and goes away.
Yeah.
That's not always the case. Inflammation continuing in the circulatory system and in the vascular system of mom, even without the placenta, causes an uprising in that later. Also, postpartum hemorrhage that can be latent or secondary that can occur up to 12 weeks after delivery. So many of the things that we see after mom goes home are things that we rely on education for, support to family members, looking out for things when they go home, how to seek medical treatment, where to go, are probably the most problematic, I would say, for after I have a baby.
Yeah.
Prior to having a baby, those preeclampsia things can occur. With appropriate treatment, we can prolong pregnancy, keep mom safe, keep baby safe until we're at a good gestational age for delivery. In hospital, certainly postpartum hemorrhage immediately after delivery and things like that do occur. Most problematic, though, I feel for most of our population in the communities is those things that pop up after you have a baby that can go undiagnosed, unrecognized, missed, those kinds of things. Probably most problematic.
Yeah, so I kind of want to talk about preeclampsia, like postpartum preeclampsia. I was reading a study, it was a couple of years ago, about how women who have preeclampsia, like their blood pressure is not subsiding. Like it might subside for a little bit, but then maybe a year later it pops back up. Do we know why that's happening? Is there any education that as EMS professionals need to educate these people? Like, hey, go to your physician if your blood pressure is over this.
Most of the time with our preeclamptic patients, it starts in a variety of ways. There's not really a good answer as to how this starts.
Yeah.
You can be preeclamptic with one pregnancy and not another one.
Mm-hmm.
You can have it occur 6 weeks after you have your baby, but never have a complication again. You can have it occur and then have a lifetime problem with high blood pressure. Most importantly is follow up with the doctor and kind of keeping track of blood pressure in your regular doctor's appointments and things like that. But there's not really definitive answer as to why these things start. Lots of suspicions of an inflammatory response with pregnancy, suspicion often that women can kind of be allergic to their husbands, like an anaphylactic reaction from conception that can start that. Really has very little to do with poor health per se. Some of the healthiest people in the world end up with preeclampsia. There are causative factors for high blood pressure, but the phenomenon of preeclampsia really starts with pregnancy, kind of gets it going because of a placental malfunction, for lack of better terminology, and the way mom's body reacts to that.
All right, so is there any like pre-warning signs? Because like let's say I go out and someone's complaining of this, they call for 911, maybe dizziness or a headache. Is there any signs that as EMS workers can be like, hey, I think you need to call your OB, or I think we need to go see the doctor, that might not be so scary right now, but could be scary later?
Commonly, the things we have moms watch out for, headache that's persistent, won't go away with Tylenol or regular headache treatment. An increase in swelling, especially ankles, feet, hands, sometimes your face. Epigastric pain that's not soothed with Tums. Changes in your vision, seeing spots, blurry vision. Monitoring blood pressure certainly at home is sometimes encouraged by providers that are suspicious. There are lab tests that they can do to keep an eye on. But the immediate presenting things are common for what high blood pressure would feel like for most people. The reason we say that can be masked, though, is especially in the postpartum phase. You are sleep deprived. Having a headache is not uncommon. You've had a lot of fluids in the hospital, and your body goes through a huge hormone change or shift in your fluid. So you might have some swelling, epigastric pain or heartburn, things like that go unnoticed because I feel like we have a culture where you're taking care of a newborn baby. You're not really paying that close of attention to yourself. So we do talk a lot to moms about how this can creep up later. And if these things are happening, please call your OB. Please go to an emergency room. Please have your blood pressure checked. Just like with anyone else with high blood pressure, very high risk for stroke, sudden death, cardiac issues, as with anyone else that has high blood pressure, but directly associated with pregnancy, for sure, in a preeclampsia type situation. Preeclampsia actually is a precursor to seizure activity, which also can occur, which then that disease process becomes eclampsia. The preeclampsia actually means before I have a seizure, not before my baby is born. As this increases, as we are lysing cells, as our liver enzymes are increasing and we're having issues, so does the threshold for us to have seizure activity, which is seizures of unknown cause. I've never seized before is definitely a 911 call.
Yeah, and can you speak a little bit about HELLP syndrome?
HELLP syndrome is a side effect kind of to preeclampsia. There's not really an answer as to why some women struggle with HELLP syndrome and some don't. It's kind of a mystery. But HELLP syndrome is that continuing destruction of my own cells. I start lysing a lot of my own platelets, very low platelet counts, high tendencies to bleed, liver damage that continues with the preeclampsia. Many of the HELLP syndrome patients are immediate delivery need. That's typically after preeclampsia has gone on for a little while, but there's not really a time frame because it's kind of a mystery as to why that actually occurs, but it is closely associated with preeclampsia.
We are changing a couple of our protocols here soon and giving Pitocin after every field delivery. Can you give me some insight on Pitocin?
Pitocin actually is given, I would say prophylactically anyhow, for every delivery. What that does is help the uterus clamp down, helps to control your bleeding, keeps that tone in the uterus and the uterine muscle. That is very, very important to control that postpartum hemorrhage. It can be hung either as an IV bolus drip or can also be given IM. Usually after the placenta is delivered. We don't want the uterus to clamp while we are trying to deliver a placenta. Definitely after the baby is delivered. When you clamp that uterus down with a baby inside, that's dangerous for the baby for a lot of reasons. So it does help control that postpartum bleeding. I know emergency rooms are starting to use that more kind of prophylactically as well. No harm, no foul. It's not going to hurt anything if it is given and there wasn't much of a reason that you could see presenting. The number one rule for postpartum hemorrhage is to try to treat before it occurs as opposed to waiting until you have an emergency. And this is just a first line medication that can be safely used for anyone.
Yeah. And are you guys using the Jada at all?
Yes. We started using the Jada, it's been a little over a year ago, I feel like at this point. It works a little differently than our Bakri. The Bakri is also an internal device that we use for postpartum hemorrhage. The Bakri works as a tamponade, so almost like pressure on a wound inside the uterus. The Jada is set to low suction, so that device is also planted but sets to low suction to help that uterus clamp down. Not to dismiss at all the use of the Bakri per se, but it just works in a different mechanism. A lot more comfortable, lots of success with it, and generally liked. Those are also stocked in our emergency departments for the same reason. Controlling that bleeding and getting things under control before there's an emergency is number one rule of treating hemorrhage.
For people out there that don't know what the Jada is, it is a device that you are going to insert into the vagina for postpartum hemorrhage. Now, you do need an ultrasound device, if I am correct, to make sure that you're in the proper place.
I think in an emergency situation especially, we're not using a lot of ultrasound. There are hallmarks on the device to know whether or not you're north of the cervix where you need to have that planted, and things like that. So you can, by feel, know where you are, as opposed to having to look. I think in emergency situations, we do a lot of things quickly to avoid situations. But the Jada is one of those that can't be placed wrong per se, which is also nice and more user-friendly.
And I believe that works on any portable suction device.
Yes.
And it is wonderful. I know a lot of midwives are using it. It's something that I see at conferences all the time now. Is there anything about the Jada that we can kind of problem solve?
I would say probably the biggest part would be clogging the little ducts that are inside with clots and material and things like that. But there are many ports for the suction inside.
I know. I like that about that.
It kind of reminds me of a self-sprinkling garden hose.
Yes.
It has a lot of different holes, little tiny holes in it that help suction some of that debris away and help clamp down that uterus. Yeah. So problem solving per se would be placement, I would say, number one. Maybe not in far enough or not anchored well would probably be the biggest part.
And that's one thing that I just wanted to add. Being the transport coordinator, I've actually seen some of these where we'll have a regular EMS system that will go out and pick one of these up. They end up clamping it, thinking that that's going to keep the uterine tone, and it actually decreases the uterine tone. So just making sure that anytime that you go to pick up a patient that has a Jada device in place, that you do maintain suction throughout, other than your transfer from the ED to the truck, and then reinitiating the suction at that point.
So let's dive into a little bit of delivery complications and the shoulder dystocia, placental problems, uterine rupture, like what that looks like, what we can possibly do to fix that.
I would say first and foremost, for complications, delivery complications, as in shoulder dystocia, much of that has to do with the shape of mom's pelvis versus the shape and size of her baby. The best way to remedy that is position changes to open up the pelvis as far as possible to allow the baby to descend. Using methods like McRoberts, pulling legs way back to open up that pelvic inlet, suprapubic pressure, so pressure on the shoulder just above mom's pubic bone can help dislodge a baby. I would lovingly say for many babies, given situation, always situational. There's never ever black and white in OB and babies. They make the rules. We just tailor our care to what they need.
Yes.
Commonly a baby that's going to be delivered in the field, at home, in an emergency room, are babies that aren't going to wait. Those babies typically kind of deliver themselves in the sense that, it's just time to come, so they do. There are ways, though, like I said, with position changes and things that can help dislodge larger babies and help them deliver safely. So shoulder dystocia is something we definitely see inpatient, pretty common, I would guess. it's really hard to tell ahead of time if you're going to have a problem. So that's kind of a think quick on your feet move in the most part.
Do you see a lot of the turtling sign, or is that just something that's in our textbook that we should ignore?
You do see turtling with pushing. Often while a woman labors, there are other things that you will see that are a little bit problematic. You can kind of anticipate that there may be problems. The turtle sign, though, you do see as the head is trying to crown, you do see the baby kind of slide back up because they are already hung up. Something to recognize and know how to treat. I would say safely for public safety, fire department, police department, our ambulance, things like that. When a baby is coming, they're going to be coming.
Yeah.
So there wouldn't be a lot of time for seeing turtle signs and things like that. Those 911 calls are usually the fear of, oh my gosh, this was supposed to happen in a birthing suite. This was not supposed to happen in my foyer.
So let's talk about the umbilical cord, because we get a lot of questions about that.
The umbilical cord, I often, describe as scuba gear, right? This is the baby's lifeline. This is how they do gas exchange. This is how they eliminate waste. This is how they're oxygenated. So most importantly is the safety and health of that umbilical cord for those reasons. When babies are delivered, sometimes you do see what we call a nuchal or a cord around the neck. Not necessarily a fatal thing at all. As babies grow, they're living with this umbilical cord. Sometimes they look like they've been jump roping. They're kind of tangled. Nuchals, though, can be problematic for delivery. If it's very tight, we've then shortened our exit, right?
Yeah.
Because we're kind of hung up that way. An umbilical cord can be cut at the perineum. We can clamp and cut that before the baby's delivered if we need to, after the head emerges and we can see it around the neck. Other times you can just reduce it. It's loose. And we can reduce that and just loop it over the baby's head just to give them a little more room. Cord accidents that do occur are often unseen. Another think quick on your feet. Keeping the pressure of the baby off that umbilical cord, if you happen to see that while you're delivering and things like that, is very important because once again, that's their lifeline. It'd be like kinking the tube to a scuba diver, right? So we want to be sure that we are very diligent about where that umbilical cord is when a baby is delivered. Always making sure, and I know when I talk to communities and students and different things like that, 2 clamps on the umbilical cord. We have to make sure that we are clamping the placenta side that will cause mom to bleed a great deal and clamping the baby side, which would cause the baby to bleed a great deal, and then cutting in between.
Delayed cord clamping seems to be kind of on the rise right now. What's your best practice for that? What if we have a mom out in the field that's like, hey, can we delay this for a few minutes? What's your input on that? What benefits is there?
I've been asked this question quite a few times. Delayed cord clamping is what providers have moved to, with the adage that the baby's getting the rest of the volume that they were supposed to have prior to delivery. After the baby delivers, you can feel a pulse in the cord for a very short time. Sometimes that delayed cord clamping is a minute, maybe a little more than a minute until you don't feel that pulse anymore. What I can say is it's a controlled practice from a provider. What happens by default, I feel, in the field and when you're kind of surprised, delayed cord clamping kind of happens anyway.
Yeah.
By the time you're getting out your equipment to clamp cords and things like that. If it's not something that feels comfortable, you're not sure, I would say that there were a lot of things about mom's delivery on her bathroom floor with her, right, that she didn't expect. So, just talking through a little bit, we're going to go ahead and do this and those kinds of things. I think there's an element of surprise and understanding on both parties when things like this happen. And once again, babies make the rules. We just do what we need to do after they've decided what they're doing first.
You talked about, so when the cord presents first, what are some tips, some tricks for our providers out there to keep the baby off that cord and to make sure that it is perfusing?
When you elevate the baby's head off of their umbilical cord, you can feel that pulse. So knowing you're getting good circulation comes from the pulsation of the cord. When you're trying really hard to keep the pressure off that cord, keep it from getting pinched, keep it from getting squeezed, keep it from cutting off their circulation, for lack of better terminology. Whatever happens to work best is what we're going to do. In transport situations, sometimes putting a patient in Trendelenburg, if they're on a cot, helps eliminate some of that. But first and foremost, someone that can feel a pulse in a cord to know that we are still perfusing and oxygenating the baby. Cord accidents is what they're referred to. There's a few different ones, but Cord accidents often attribute to a lot of term fetal death and things like that. Because once again, if the baby's not delivered and we have something happen with the cord that is unforeseen or something that surprises us, that's their lifeline. That's how they survive. What I can also lovingly say, though, is we have a lot of success with just making sure that there's circulation in that cord.
Uterine rupture. What does that look like? Is there anything we can do for that besides drive fast?
Uterine rupture is one of the biggest obstetric emergencies. Commonly would happen in a mom that's had a previous C-section or uterine trauma, where that tensile strength of that scar tissue is not as strong as that once would have been. The uterus is a muscle, so it is made to stretch, it is made to contract, it is made to do a lot of cool things, but with the added pressure, growth, weight of the baby, the action of labor in itself, sometimes those uterine scars can start to split. Women can also spontaneously rupture their uterus for no unforeseen reasons. And when those things happen, not only do we have a very large muscle group internally bleeding into mom's abdominal cavity, we also have a baby that can escape the uterus and be outside of the uterus, which is very dangerous also for them. That is not an environment in which they are designed to live. So it is a life-threatening emergency. Common symptoms, I think of that for the most part, because monitoring equipment and things like that aren't necessarily available to watch these things happen, would be excessive bleeding in mom, kind of like over-exercising, intense abdominal pain with your contractions, a feeling of doom and anxiety as mom's starting to bleed. If she's bleeding during labor while those muscles are tearing, there is a lot of shock factor, anxiety, shortness of breath, ringing in her ears, blood pressure spikes, and then will quickly plummet, things like that. Mom has a lot to offer in those situations. She knows something is not right. It is a lights and sirens emergency. However, that needs to be remedied quickly. If the baby can be delivered vaginally or it's happening while the baby's delivering vaginally, baby would be out of the dangerous hostile environment, but mom then is definitely a medical emergency.
So how would you suggest dealing with a mom that is crashing and baby is still inside? Do we treat mom like normal? Should we have certain considerations for baby?
I guess unspoken rule for pregnancy is in any kind of complications with a pregnant mom, mom is chosen as the survivor. So whatever needs to happen for mom's safety and survival is what we do. Unfortunately, sometimes that is not safe for the baby, not okay for the baby, but if mom's life ceases, the baby will not survive without her in those instances. So choice is always for mom's safety. So TXA, yes, pressors, anything that you would give to help her stabilize and keep her going until she can get to a safe place, regardless of the fact that she is pregnant, is always the judgment call. When it comes to quick choices, mom is the first choice.
Yeah, and I think that's something that I actually learned early in my career and I was very upset. I was actually in an ED, and we had a mom come in with multiple gunshot wounds, and it's we're there as the NICU team waiting on baby's arrival as they are trying to resuscitate mom, and it's the same thing when you're out in the field. Is you really just have to make that focus, as Kim said, on mom. Doing your fluid resuscitation, following those trauma protocols is really what you're getting down to, and making sure that you save mom's life, because as Kim said, without mom, you're not going to have a baby. And one thing that I wanted to add too is remember that we all live in this environment of high stress, high work. As the stress goes up, we know that the task workload goes up. So just remembering that even in these situations, we have to take time. We have to think. We have to take a breath. And if you don't feel like the expert, you have your partner. Talk amongst each other, do what's best for the situation, or come up with a plan. I know that we're doing that very efficiently and very quickly, but at the same time, you have to calm down, because without that inner air of calmness, it's going to be very difficult to think properly and then make the right decisions.
Can you give me any insight on OB desert areas? I know a lot of places are shutting down their OB centers. What are you seeing with that?
We have actually worked as a health system over the last year and a half when a lot of this started, educating more of our emergency room staff that have lost family birthing centers in their hospital. We have worked with local EMS a little on education to them, NRP skills to them. What do we do? How do we transport? Having to think very quick on our feet about transporting mom and baby together. How do we do that safely? There has been, especially in our northern communities with many of our southern Michigan cities also, closing their birth centers, very large Amish population there with limited resources as far as vehicles sometimes to transport to hospitals and things like that, showing up more in emergency rooms, delivering at home with some complications. So really, first and foremost, we as a health system have worked diligently in trying to prepare our emergency room, local EMS, things like that, our maternal transport, talking to them a little bit about how you may be showing up for some things. The goal is to always move mom out of an emergency room, if possible, in those moments, because emergency rooms are not equipped to keep a mom long term, to have a baby. We're certainly not inducing moms in emergency departments.
Yes.
But I'm driving to my hospital to have my baby, and all of a sudden something doesn't feel right. Mom notices the H, the big blue H on the highway, or a sign that says, emergency it's an emergency to her. So what we are seeing is actually a little bit better planning as far as our providers are concerned about making sure patients know where they should go to deliver, where they will be seen, but kind of bringing the community around the services in general to have safety for mom and baby. This has only contributed to OB deserts in a lot of communities as well. I think we are such a diverse melting pot in Fort Wayne. Lack of resources in different parts of town, transportation and things have been things that we have battled and have definitely gotten better because we have a huge community of people that want to see a change. And then this just further complicated things. But I do feel like with training and talking to specific groups about how they treat, what we can do in the short term, what our goals are as a health system, everyone's really come around and rallied around for safety. I had an emergency room nurse tell me one day, pregnant people are fine, but they scare her because one person should not walk in her door and two people leave. And so not necessarily their favorite population, but everyone is doing an amazing job, wanting to learn, hungry for knowledge, asking questions.
Yes.
And I think that's how we combat this problem, is the community coming together.
Yeah, I noticed a lot of protocol changes kind of throughout, like with EMS. So the one I was going to mention, and what we already did, was Pitocin, getting that on the trucks. Also, mag sulfate for preeclampsia, and depending on what their protocol says, like that's also can be given after, like for the postpartum period too. TXA for postpartum hemorrhages and stuff, and just more education on that. Is there anything specifically EMS, emergency services, you want to tell the people out there that are listening, or medical directors that are thinking about changing some things for OB?
I think the biggest thing I want to say is thank you. Thank you for being willing to step outside of your comfort zone, stepping outside of your scope. So many responsibilities for everyone. And then adding one more thing that many, I think, hoped would never be their responsibility. But it does, in this sense, to cheesily say, it does take a village to take care of our moms and babies. It takes a lot of professionals, people that are willing to help, learn, be involved, intervene to make this successful and to keep safety of our patients first and foremost. If there are questions, if you're moving towards a new model that's uncomfortable, always reach out with questions. Ask your family birthing centers, ask other hospital personnel that are versed in this, reach out to your medical providers and ask the questions. What can we do safely? What is in our scope? How do we modify our treatment? Because in the end, everybody kind of working together will make this better, because it's what we have to work with now. So as any healthcare provider in the whole wide world, we're just going to think very quickly on our feet to make this a success.
I think that's one thing that's really important that Kim just said too, is ask. If you're coming in and you're dropping a patient off and you have questions, don't hesitate to ask. I mean, obviously, you're going to pick the right moment. If you have time and you can, you're still timed out on your run, wait an extra 10 minutes, ask that question, get the answer that you need, and then make sure that you're sharing it with your partners. Come back to Caitlin and say, hey, this is what we learned today. That way you can share it across the organization. One thing that we're trying to do right now, Parkview and DuPont, we're trying to have a good collaboration between our transport teams to really support not only our Allen County community, but all of our surrounding communities as well. With that being said, that's obviously why we're here today. We want to be here to answer questions and help other teams. And Kim touched on this earlier about reaching EMS and being out there with the community teams to help them out. Anybody that hears this, if you have questions or you would like education or things like that, reach out to your local hospital systems and see if there's something that they could do for you. In the state of Indiana, I'm just going to throw this in here, but in the state of Indiana, we now have a perinatal network. And within that perinatal network, which encompasses our women's and children's hospitals throughout the state, we're working together to help educate all of the systems that are out there. We know that we have those OB deserts and they need help. So what happens with those hospitals is they attach to a perinatal center like Parkview or DuPont. They pretty much come under our umbrella, and then we're responsible for helping them maintain education and doing things like that for them so that they're up on the latest and greatest. I think overall that really helps as systems. One other thing that I wanted to throw in there, just because FWFD is really local to Fort Wayne City, is with all of these EDs, just freestanding EDs that are popping up. You may see from time to time that your ambulance company actually gets called to transfer a patient from one of those what we call a level 0 facility or a non-OB facility to a level 1 such as Randalia or a level 2 such as Lutheran on Jefferson, and then you've got your level 3s with DuPont and Parkview, depending on what the situation is. So with EMS availability, obviously being an issue statewide, countrywide, you may be the group that gets called to help transfer one of those patients.
And I know this is kind of Parkview specific. When do you activate your postpartum hemorrhage? Like how much blood do they lose before that gets activated?
Postpartum hemorrhage, actually, we start to treat as nursing staff at about 500 mLs lost. ACOG requirements, or what the physicians follow, is more at 1,000 post-delivery. That's done through quantification. So we do weigh, measure the amount of blood that is lost after a delivery, whether it be vaginally or C-section. Most importantly, especially I guess in field, most importantly is symptomatically of mom. So a postpartum hemorrhage would be treated symptomatically and as a trauma, as in any losing large blood volume. The benefit a pregnant woman has is that God already knew, I guess, that they were going to lose some blood when they delivered a baby. So there is extra volume available for mom to utilize, but can quickly be lost. Kind of keeping an eye on symptoms, blood pressure, the way mom feels, the amount that is bleeding. Measuring those things outside of hospital is something that isn't commonly going to happen. Once again, treating in the moment, right? The trauma. Yeah. So medications like TXA, Pitocin, Cytotec, things like that, Methergin, all kinds of postpartum hemorrhage medications that we have available to help stop that, stopping it before it gets too out of control. Moms that lose gross amounts of volume run the risk also for DIC, just like anyone else that would be hemorrhaging a great deal. Kind of understanding, what looks to be a lot sometimes is not as much as we think. What looks to be not so much is actually more than we know. And it also depends, too, on what kind of surface. Some things are made to be much more absorbent. Some things are made to be not as absorbent. There is a lot lost, not just blood, but fluid as well. After a delivery, amniotic fluid that's left, even if mom is ruptured, things like that. So taking that into account, adding water to blood volume can actually make it spread a little, make it look like a lot more than is actually there. The number one thing I think to watch would be the amount of free flow bleeding and clots that are being expelled after delivery. most of the time, mom is not going to have heavy free flow bleeding from her vagina. If that is something you see almost as a trickling faucet or more, that is problematic. That is something that's not stopping on its own. Moms can suffer actually from postpartum hemorrhage, a secondary postpartum hemorrhage, up to 12 weeks after delivery, which is very scary and frightening to many because you think you're out of the woods. Often secondary things are caused by comorbidities, clotting disorders. Once again, mom receives a lot of education, family members' education on when do you return to the hospital, when would you call for help, passing blood clots, lightheadedness, dizziness, short of breath, a lot of the things that we would educate anyone on what massive blood loss would feel like to you. People that are hemodynamically unstable obviously are going to need some kind of intervention. And so it is very important to seek medical treatment.
Yeah, I had that exact run where mom, she was just doing laundry. I was just sitting here doing laundry, so I felt a pop. So I wasn't doing anything bad, nothing that no one told me I should not be doing. And yeah, just was like a faucet. It just kept coming out. Ended up giving TXA, fluid. We did not have Pitocin at that time. This was kind of a while back ago run.
I think one thing is, so we talk about all the meds and just doing basic measures, and I know that, okay, everybody's got it in the back of their head that they need to do fundal massage, but
Yeah.
Kim, what does good fundal massage look like?
Good fundal massage, very deep, very aggressive, hard rubbing on the top of the uterus, supporting the lower uterine segment while you're doing so. That is done a lot after mom has her baby for obvious reasons. Can be used as a way to decrease uterine atony if this were to happen later. Commonly, a secondary can happen. Mom could have a uterine infection she's not aware of. Sometimes what you notice is that fundus is actually firm. Massaging doesn't do a lot for a firm uterus. They could be bleeding for other reasons. So mostly the massage is used for uterine atony, when the uterus feels boggy, when it is flimsy, when it feels almost like a bowl of jelly. It's kind of jiggly and not firm. The fundus should feel like the top of a cantaloupe is what I often tell people, that very firm, round, symmetrical, should be midline with your belly button and things like that. So things to feel for. But if the uterus were to feel anything differently than that, likely does need some fundal massage.
And that does not feel great. Me being a mom does not. All the women in here are shaking their
You're
head
not gonna
like,
make friends.
yeah, you're not going to make friends with it. Just kind of prepare mom for that. She most likely already knows, but if it's a new time mom and you got to do fundal massage, just prepare her. That way she doesn't kick you.
Ideally.
I have to say that I asked that question more because I'm going back to get my EMS. I'm going back to recertify as an EMT, so I wanted to know the answer. For myself
what
as well.
that looks like. And you brought up early transporting mom and baby safely. Let's talk about that in the ambulance, because that is a big thing. It's like, well, how am I transporting mom and baby? I have mom just hold baby. Well, what if the ambulance flips over?
I've been doing some education on this
Yeah.
because there are devices out there that you can use. In the EMS world, it is a little more difficult. How do we get that baby safely to the facility and, keep them warm and dry and, make sure their blood sugar is okay and do all the things that are required. I'm not sure what equipment you have when it comes to that, but just to put a plug, Furno actually has what is called the Kangoo Fix, and it is a baby transfer device that allows you to transfer baby and mom together. It straps directly to the seat belts on your cot. Baby is on mom's chest, and it allows a safe transfer of baby and mom together to get them to the closest facility.
That is really nice to know. I think a lot of our ambulances around here, I shouldn't speak for everyone, but just kind of general, have just the PD mate. Let's say we don't have that device. Okay. We don't have that device, don't have a car seat, mom and baby. What's the safest way?
I would say just from history and doing this for as long as I have that, you have cross belts on your you have cross belts on your stretcher.
Mm-hmm.
Wrap that baby up to keep them nice and warm. Make sure that they have a hat on. Get them on mom's chest. Or the other thing that you could do, especially if it's a small child or a preterm kid,
Mm-hmm.
is stuff baby inside mom's shirt.
Oh, yeah.
Get baby inside mom's shirt to where they're skin to skin. You want to make sure that baby is naked. You will still put a hat on them to reduce some of the heat loss, and then strap that baby in, have mom hold and strap the mom and baby in together at that point. And that is your best bet to keep that baby warm and less stress on their body temperature. So
Skin to skin is always encouraged after delivery, mostly because mom's body is designed for thermoregulation for her infant.
Yeah.
So if the baby is cold, her body will warm to warm the baby, and vice versa. If the baby's a little hot, mom will cool to keep the baby cool and at a constant temperature. Helps with bonding, helps with pain, helps with blood pressure, helps a million things. First and foremost, especially a baby born outside a facility, maybe they are a preterm baby, even just a term baby. Babies can get cold very quickly.
Yeah.
When you have a cold baby, you have a baby that struggles with a lot of things, respiratory, blood sugar regulation, a lot of things. They burn through the energy that they have initially just trying to keep warm. So at all costs, if transporting both of them together is what should happen if everyone is stable, however you can do that safely is definitely preferred, and keeping them together definitely important.
Yeah.
So all of those measures. Skin to skin, though, is naked skin to naked skin. So on mom's chest, no diaper, skin to skin, right in between her breasts, on her sternum. The baby will fit there perfectly and lay there just fine, keeping them cuddly. And that will help with thermoregulation until you can transport.
I love the OB world. It's amazing how women's bodies are designed to take care of their baby. And just for our listeners out there, we are going to be doing a couple of more segments talking about neonate resuscitation here in a second, and specifically peds. So stay tuned for those episodes. I want to thank you guys for coming on to this episode. And guys, just remember, leave it better than you found it.